Um, as you know, this webinar will be recorded. It's on heart failure for the Tier 2 cohort. I will start with the slides. Can you see my slides? So this will be a little bit of housekeeping. Please don't hesitate to use the Zoom chat if you want to have put any comments or any questions, and we may try to answer them. There'll be a little bit of the time at the end for questions as well. Oh, no, I just need to take. Somebody has written something. Yes, please be careful how you use the screen there. There will be time for questions at the end. There will be a survey as well at the very end to get your feedback, after which when you complete it, you'll get a certificate. And of course, as always, there will be a recording up on our website. You can contact me through my email to get basically access to the website, or you can just put BHRC Pen long-term pathways. I will just stop sharing to try and get rid of this red line. Gosh, I have no idea what happened there. Let's see. All right, brilliant. These are the speakers. We have Dr. Danya Shoab, lead clinical pharmacist Manpreet Saini, and Dr. Uzma Haq, as well as, of course, senior health and wellbeing coach G. Gahir. Danya, I shall let you start. Thank you very much, everybody.
Hi, everybody. Thank you very much for coming to our Tier 2 cohort, where we will be looking at how do we prevent the primary prevention of heart failure and what are the impacts of early intervention. Next slide, please. So what is everybody's understanding of heart failure? So we know basically the two processes, the way the heart works. It pumps blood out and pumps blood, and blood comes filling in. If either of these functions don't work, then the heart starts retaining fluid, it starts not working properly, and then the heart goes, and then that's when the heart starts failing. Next slide, please. So basically, again, just going back to what happens is when the heart can't fill, what could be the possible causes for it? The chambers start, the normal muscle that helps with the contraction and relaxation, they get stiff and thickened. The heart can't pump properly, or the chambers become quite thin, which results in the pooling of blood. Next slide, please. So what are the risk factors? My colleague G and Manpreet will be talking about this in more details, but just the very common things which we think when that could prevent it is, you can see all of these here, but the things that really help us as professionals are that we deal with are smoking, having unhealthy food, just going out, fish and chips, all of that. And all of these factors that we cover as healthcare professionals, you can see it's like a vicious circle. You end up being diabetic, then hypertensive, which results in you not being able to exercise. Obesity follows on to having heart attacks or heart diseases, results in all sorts of things going wrong with your heart. Next slide, please. So how is it true? So what the heart does is it also affects the kidneys. When the kidneys stop working properly, again, there's more pooling of fluids. And then this starts affecting the kidneys as well. So it's like, again, a vicious cycle. Next slide, please. So again, very common for here, my pharmacy colleagues, any heart failure that's diagnosed by the specialist, what do? We look at heart failure with preserved ejection fraction. which we manage the common conditions. But then again, I think the most important thing are, rather than pills and potions, offering the personalized care program, which my colleague G will talk about, because we can give as many medications as we like. We can get them to follow it. We can look at compliance, but I think the core is the personalized plan, which needs to be adjusted in order to maintain status quo, maintain them on the way it is. Next slide, please. So again, a heart failure with preserved ejection fraction, with the symptoms, we look at medication, which my colleague Manfred will talk about the medication management in more detail. But basically, if it's recent hospitalization, looking at the risk factors, looking at reassessing the left ventricular ejection fraction, and looking at the modifiable risk factors and what are the things that could be changed and what are the things that we need to prevent from worsening. Those are the things we're going to focus on today. Next slide, please. So again, this is just the British Heart Foundation. How do you do cardiac rehab at home? Again, our recording will be available. You can watch up the rehab videos and how do we do with that. Next slide, please. Again, yeah, I'll now hand over to Manfred, who's my lead pharmacist at the Willows. He's the lead educator as well, who has pharmacy trainees and has recently won the Northeast London, actually nominated for the Northeast London Best Pharmacist Award. So hand over to Manfred.
Okay, thank you, Dr. Shoaib. Okay, so first slide. So you probably saw briefly the algorithm for treatment for heart failure. So basically, what I'm going to do today for you is just to talk about each of those groups. Now, we've got your ACE inhibitors, your ARBs, and also the ARNIs. Okay. Basically, the European and the UK guidelines recommend ACE inhibitors for all patients unless it's contraindicated. Most of us probably know the fact that if they are of Afro-Caribbean background, then good idea to use ARBs instead. The European guidelines also recommend ARNIs if they are still symptomatic, and most of us have probably seen these things being prescribed. Slowly but surely, I'm seeing more and more of it. That's when we're talking about our Entresto, which is the sacubitril with the valsartan. However, for those patients who were previously on an ACE inhibitor or an ARB, there needs to be a good 36 hours. There needs to be a good 36 hours needs to elapse before the Entresto is started. And obviously, if the patients who are taking ACE inhibitors, if they have problems such as your coughing and things like that, then you can consider ARBs for them as well. Next slide. Right. So what we have here. Okay. So first of all, you've got the examples are well. First up, we've got here the ARNIs, which are angiotensin receptor. I could just about say this neprisilin inhibitors. That's your Entresto, your sacubitril, and your valsartan. Then obviously you've got your ACE inhibitors, which everybody knows, and then your ARBs. The American Heart Association and American College of Cardiology and Heart Failure Society of America, they recommend your Entresto for patients which have heart failure with reduced ejection fraction when they have class 2 or 3 symptoms of the New York Heart Association classifications. And as I said, if you can't take Entresto for whatever reason, any contraindications, any unacceptable, intolerable side effects, then you've got your ACE and ARBs as well. Next slide, please. Okay, your beta blockers. Apologies, we've got a couple of I don't think they will necessarily work, but we can give it a try. We've got some references in there, but the reason why we use beta blockers, okay, yes, they probably do slow down the heart, but they do increase the contractility of the heart, and therefore they have been shown to decrease morbidity and mortality. So usually that's the way I explain it to my patients, the fact that it does slow down your heart, but makes your heart beat more strongly. Um, And obviously, for those reasons, you have to make sure that the patient isn't suffering from bradycardia. Usually, that's a heart rate of less than 60 beats per minute, usually. If they're having any worsening airways disease. Now, most of the ones which typically end up being used are your bisoprolol and things like carvedilol, which are cardioselective. Now, remember, they are not cardio-specific, they are cardioselective. So therefore, they shouldn't really affect anybody's asthma. They shouldn't affect anybody's COPD, but it's something that just you need to keep your eye out on. And then obviously, if they've got unstable or low output if they've got low ejection fraction, then that's something that we need to think about as well. But as I said, typically you're talking about your bisoprolols, your carbidilols. I don't see this so much, but you do get your sustained release metoprolols as well. Next slide, please. Okay, right. So the European Society of Cardiology guidelines recommend nebivolol. Nebivolol is a cardioselective beta blocker with nitric oxide mediated vasodilating properties. And that's something that has been found to be effective and well tolerated. It's a well tolerated treatment in heart failure patients aged 70 years or more. And also another good thing about nebivolol is that there's less time taken in the up titration of it as well. Now, carvedilol, a COMET study which was carried out in 2003 showed that carvedilol was superior to metoprolol. Probably one of the reasons why metoprolol isn't used so much. But there isn't any evidence of any superiority over other beta blockers. So it just seems that bisoprolol just happens to be fashionable at the time. And the fact that moderate doses of nebivolol are less likely to cause your hemodynamic effects. So you won't get patients sort of falling over, feeling dizzy, and things like that. Whereas with the other beta blockers, the chances are a little bit more. Next slide, please. Okay, so moving on to the aldosterone antagonists. So we're talking about your spironolactone. Again, something which I'm not seeing used so much. I'm beginning to see the emergence of eplerenone now, and that's been found to reduce mortality and morbidity with your heart failure patients with reduced ejection fraction. Obviously, we have to use it in caution for patients who have renal dysfunction. It can really only be initiated if the eGFR is above 30 mils per minute. And also because they are potassium sparing diuretics, as most of us probably know, so we need to make sure that the serum potassium does stay below 5. And obviously we need to keep an eye out on it all the time anyway, because it can cause hyperkalemia. And the US guidelines tend to say that if your potassium levels hit 5.5 or more than that, then quite simply just to stop. I mean, with regards to the cautions that I gave earlier, that's the European Society of Cardiology guidelines. They usually recommend just seeking specialist advice for these patients. Okay, so next slide. Okay, so now we're getting to the new kid on the block. That's your SGLT2 inhibitors. Most of us do recognize it from your diabetes, but as we know, it's kind of caught fire and it's actually got a very prime place, shall we say, in heart failure. You've got your dapagliflozin and empagliflozin being used. They're the ones which I see commonly used, and it's recommended for them to be used with your ACE inhibitors or your ARBs or your ARNIs, a beta blocker and aldosterone antagonist as well. And it can also be used regardless of whether the patient happens to have diabetes or not. Okay, so let's go to the next one. And finally, you have diuretics. Now, that's obviously something that you have to think about when, depending on how your patient is presenting. Obviously, if your patient is presenting with shortness of breath and is a lot more congested, you may need to consider your diuretics. But so therefore, for fluid overload, it's definitely recommended. Or if there's any symptoms of congestion, as I mentioned. In patients with hypertension and only mild fluid retention, a thiazide diuretic can be considered as well. In patients with stable congestive heart failure, loop diuretics are usually the preferred agent. If they have a reduced LVEF, that's left ventricular ejection fraction, then you can use it with other therapies as well, such as your ACE, ARBs, ARNIs, your beta blockers, and your aldosterone antagonists. But usually most people tend to start with loop diuretics, so we're talking about our furosemides and our bumetanides. You can add in the thiazide diuretics or thiazide-like diuretics, so usually it's one or the other. Depending on the patient's needs, I suppose. You would need to monitor the patient's use their sodium, potassium, their kidney function, and the whole aim of it is that so that they are no longer congested, because that's one of the things that the patient has more of the symptoms with when they are unable to breathe. You want them to remain asymptomatic. You want them to maintain their dry weight at least, and just sort of be all that much more easier on the heart. And so therefore, but if it's a bit easier on the heart, the patient will feel that through number one, not being so congested, number two, not being so short of breath, and number three, they would have a bit more of an improved exercise tolerance. Next slide, please, rather. Okay. Other things which I'm actually once again seeing less and less of are things like your isosorbide nitrate. In all honesty, it's been a very long time since I've seen this one. Hydroxyzine that I'm beginning to see, yes, as well. Ivabradine is something that I see as well. Actually, that's actually probably out of all four of these, I'm beginning to see ivabradine a few times as well. And obviously your digoxin, which helps with the rate of your heart rate, basically. And next slide, which is the final slide for me. Okay, is your non-pharmacological advice, which is something that you would say to even somebody who happens to be healthy as well, like the lifestyle changes that you need to try to make, your exercise training, and that's something that which can be offered as well. Dietary changes as well. So typically anybody who's sat with me will know that my mantra is less sugar, less fat, less salt, more fiber, smaller portions, and just a general health maintenance, really, and avoiding excess sodium intake, because obviously that would add to the blood pressure, which obviously makes it all the much worse for the heart. So I believe that's all from me.
Thank you very much. And we hand over right now to Uzma. It's you now. Thank you, everybody.
Hi, everyone. I'm just getting my slides up. So can everybody hear me? I know I can't see people, so don't know. Yes, you can hear me. Good, lovely. So I'm a GP at Gable Surgery in Dagenham. I'm also a PCNCD, and I'm an educator, part of the training hub. Kind of in my day-to-day role, I have an interest in frailty. So I have been working with the local ICB in the BHR patch to deliver services for frailty. So I thought, I think now, because this is a tier 2, maybe we could discuss frailty a bit more in detail, and then we will add more complex cases for you in the next webinar, which is roughly about 4 weeks away. So on that one, we will share details with you later. Yeah, so I don't know if anybody has any questions or would like to say something, please use the chat function, and Yasmina or Manpreet and Dania, they will be keeping an eye on it, so they'll help me answer those questions. So, but I don't mind. You can raise your hand, and I don't mind if you want to speak in the middle, because I think the previous speakers have done really well. They've stuck to their time limit, so I'm going to try and do that as well. But if you've got any questions, please, we're happy to hear your voices and take it forward. So I thought for the frailty bit, we could try and understand frailty and how it's relevant to heart failure. There's also end-of-life care issues that we might come across in heart failure, and how personalization can help. That will be something that I will talk about at the end, and that we can I can hand over to G at that point. But with personalization, I feel there are bits which are sort of medical personalization. So, you know, Manpreet spoke about lots of medications, but it won't be appropriate to put all of our patients on them, even though there's all these things that medically we can use to help them to take the load or the pressure off the heart. So we can reduce the heart rate, we can give them blood pressure medications like Manpreet spoke about to reduce the pressure on the heart, so it doesn't have to pump as hard as it has to. We can give them nitrate, so that you know, it's vasodilate, so it makes the vessels that are bringing the blood to the heart or taking blood away from the heart a bit bigger. So that takes the pressure, so the heart doesn't have to really pump blood against a lot of resistance, or the blood will flow easily into the heart. It's not, you know, so there's different ways if you understand where the problem is in heart failure, because every person's heart failure is different. So diabetic, for example, get type of heart failure where their echo will look normal, but when you look at the echo in detail, you will notice that they have a preserved ejection fraction. So there are ways of telling that, and I don't know how we can do that. If you feel you would like to learn more about that, we could pick that up in the T3. So you could say that in the chat if you'd like to know more about how you pick up preserved ejection fraction. So diabetics typically get that. These will be our younger patients, so they're not aware of it because they're not getting symptoms. And what happens is that how we measure ejection fraction is a percentage of blood that's coming out to the percentage of blood that's going in. So in diabetes, when the heart starts to get stiff, it can't expand, so it can't have the blood flowing in, then there's less going out. So as a portion, the ejection fraction is preserved, so it's preserved ejection fraction. So that is a difficult type of you know, heart failure to treat. But the new kid on the block, which is a diabetes medication, is supposed to be very good in both types of heart failure. So you'll be seeing a lot of non-diabetic patients on this medication. So they will be coming our way in primary care, because when they're started in secondary care, you know, there will be questions about it, and then they might feel more closer to you or trust you. So they will want to know a bit more about these drugs. I put up this picture here to just explain, you know, the circle of like, you know, how when frailty starts to progress, you know, there's decreasing benefits from long-term, you know, interventions that we do for our patients, you know. But it's a very small portion of patients that we do see a lot of them in Barking and Dagenham. For some reason, we have frailty is not just a something that affects older people. We have a lot of younger people, because if you look at the latest JSNA, which is the, you know, joint strategic needs analysis of our population, you will notice that people in Barking and Dagenham live very short, healthy lives. So they develop one or two long-term conditions like heart hypertension or diabetes at a very young age compared to the other boroughs. So, and this is generally the case across all the three boroughs. So wherever you are from in Nell, this is generally the case. But Barking Dagenham has the shortest. But for different long-term conditions, it might be more in Barking Dagenham for hypertension, but less in Redbridge. There might be some little variations there. So it depends on how you look at the data, but generally they spend. But what this means is that if it's poorly controlled in their younger years, they're more likely to become frail as they get a bit older. I'm just going to talk a bit about what is frailty. So it's the loss of their physiological reserve, which is what helps people bounce back when they fall ill. So if they have a fall or if they get a chest infection, how quickly are they likely to bounce back? So if it's a younger person, doesn't have hypertension or diabetes, they seem to be fine in a week's time. Sometimes they don't even need to take time off work. So, but sometimes people with diabetes, they get affected really severely, or if they've got COPD, their chest infection really zaps all energy out of them. They can't just go to work. They can't even look after themselves. You know, and the longer they spend in bed, lying down, the mucus and stuff settling on the chest can become bacterial pneumonia, and they sometimes get, you know, the thing we hear about double pneumonia. So they started off with a virus and they end up becoming bacterial and they're needing antibiotics. Sometimes they need even hospitalization because they just can't cope with it in the community. So frailty is now being coined as a long-term condition as well. It's been recognized as that. So it's part of this long-term conditions training things we've done that. So sort of predictors of how you know someone is becoming frail is you can see that they're needing a carer or their needs are escalating, and this kind of tells us about the future crisis risk, and that's how we can work with a health and well-being coach and our care coordinators as doctors to actually start planning socially as well as medically for their crisis and the risk of hospitalization that they face. They do have adverse outcomes and it's quite severe. It's like they look like you'd seen them 1 week and they were fine. They catch something over the weekend. They go to hospital and then you hear that they've passed away. So it's quite fatal, frailty coexisting with heart failure. They do have reduced life expectancy as well because they're more likely. It's kind of like there's a one. So if there's a 1% chance of somebody needing ITU after a chest infection with heart failure, that 1% is at a very lower rate. So it's very easy for them to tip over into that really rare complication of getting so ill. So initially you would notice that they start to fall a lot. They'll have a reduced mobility. So people who used to come to the surgery suddenly, you know, they're not coming to the surgery anymore. They're requesting home visits. So they could make the occasional trip to the local Morrison's or Tesco, and you might see them there. And then you think, well, you go there, but you won't come to your GP. And that's just, you know, life, I think, because people don't always put that value on health as they do on food. Because if you look at the Maslow's hierarchy of needs, the triangle, you have to deal with your basic food and, you know, your basic needs first, and then you start thinking of health. So it's how do we, in our area, the cost of living is huge. So people are still focused more on their initial day-to-day living. They'll manage that. But then when it comes to their health, they won't find 20p to buy paracetamol. They would rely on us to help them. So it does feel like a lot of burden on the workforce as well to help kind of make their ends meet, which, to be honest, is not really our role. But I think more and more we will need to be a bit more careful about that. And that's why we've got personalization roles, we've got care coordinators, you know, to help us with the things that us clinicians are unable to match for them. So it's lovely to see a whole mix of people here today on the webinar. We're a whole big team looking after this one person, and the goal is to keep them healthy and give them quality of time. So presence of frailty and heart failure together is an increased risk of dementia for them. So they will be more likely to develop other things which will make them even more frail. And the severity of dementia actually correlates to the severity of the frailty that they have. So especially when there's other comorbidities existing like COPD, coronary artery disease, if they've got atrial fibrillation, they've had a stroke, and now they've got CKD as well. It's a whole syndrome. It's like loads of diseases just coming together. It's like a recipe for disaster. So these patients are very complex, and you will need help with secondary care. You will need help with your care coordinators because they forget their appointments, they don't get the transport. The care coordinator can help with that, make sure that they're attending their hospital appointments, give them a call after their appointment to check if they made it. If they didn't, then to help them reschedule it to get their transport done. Also, there might be lots of things was mentioned in the actual appointment, which, you know, if the patient doesn't understand, because health literacy is very low in our area as well in Nell. So if they don't understand it, then they're less likely to follow it, and they're less likely to trust that a physician if they don't understand what they said. So together with our whole big team, I think we can make a big difference with compliance, working on their comorbidities, getting them to feel a bit healthy and reduce the progression, because these diseases are palliative. They don't go away, but you can reduce the progression or the impact it has on their quality of life. So they do experience a lot of dependency on others for their daily life. There was like a study about people in Tower Hamlets. So there's the same types of families, ethnicity, diseases living in Barking and Dagenham were doing worse than the Asian families in Tower Hamlets. And the only difference they found there was that these older adults lived with their family. So they were in a household which is nice and warm. They were getting food on time. They didn't have to worry about paying bills because their family would do that for them. But the adverse outcomes that we saw in Barking, Dagenham, and New and some of the like Havering was these. There's a lot of, they live on their own. All these quite a lot. They depend on carers and they depend on family and friends for their activities of daily life, which does take its toll if things are not being done. If they haven't paid, they're sitting in the cold. Yeah, and adding frailty just heightens all these symptoms. So there are medications, but we'll have to titrate it according to what people can actually take. So we need to recognize frailty, recognize when they're getting worse, because they do deteriorate very rapidly and it gives poor outcomes. So personalization, there's a comprehensive geriatric assessment, which you can use in younger people as well, not just elderly patients, and it can be modified. And we're trying to do that through proactive care, where we will bring sort of people from different organizations, so like social services, NELF, you know, all your secondary care team to work together with the GP and our personalized care roles, such as care coordinators, to work and help that one patient. Obviously end of life as well, because heart failure, quite lots of them, when they're severe enough, their life expectancy is less than 6 months. So recognizing who will be in that cohort is actually very, very important. So they will be very, very breathless, even at minimal you know, exertion or rest. So stage 3 of the NYHA, you know, you need to be aware of. So there is a frailty score, Rockwood. So you can, it has different levels on it. Sorry, I didn't put the graph here, so you could the picture. But if you just do Rockwood, then it will come up. 7 or 8 is the one that you're looking at when they're becoming very dependent. They start to lose weight, and there's poor oral intake, and they just can't be bothered to eat or can't be bothered to even make food for themselves. And this compromises their physiological reserves. And so if they catch a chest infection, they're likely to pass away or to need hospitalization. And every time they get hospitalized, they lose their muscle mass and they get even weaker. So this is where personalization of care from a medical point of view would really help. And I think a GP is very well suited to do this, because you know the patient, and your team that you have with the health and well-being coach and the care coordinators, they can actually make that difference and work on them with you. If you're interested in personalization, there is this website, the Coalition for Personalized Care.org.uk. And this website has a lot of information, a lot of toolkits for you to utilize and use, and how to make the best use of all the team that is available to you in your PCN. And I know it's a big health inequality, because some PCNs have a health and well-being coach and some don't. So it might be worth a conversation that you can have with your PCN clinical director, that if you would like to have a health and wellbeing coach or a care coordinator, I think your recommendation will go a long way to help these residents to actually get the benefit of the whole team, not just the doctor or the clinicians that are looking after them. But equally, if you don't have one, then NELFT, your local community services, will have one. So it will be worth discussing it with the local heart failure clinic if they could help get them a health and wellbeing coach. Thank you. That's all from me. Any questions? I'm happy to take them. Thank you. I am just trying to take this off, but yes, stop sharing.
There's a question in the chat, Uzma,
Yep.
that should we be doing, sorry, my chat's skewed. Should we be coding Rockwood score on EMIS to help HCP have an understanding of patient, as during hypertension reviews for pharmacists, this can help provide a holistic blood pressure target. What do you suggest?
Yes, I would say please.
Yeah.
Every time you see somebody, it's just like you just with your eyes, you can tell what level they are, and just coding it in EMIS. It helps when they get admitted as well. The geriatricians have been asking me to make sure that people are coding it, because it really, really helps them when the patient presents in A&E, so they have an understanding of how much a person has deteriorated since the last time somebody's put a score in. And yes, it does help the whole team to actually see what Rockwood score it is, and then you can and then that actually tells you how much you're going to intervene and how much interventions or how intensively you're going to manage a condition. So that's really helpful. I think it's worth doing it. Thank you. Thank you, Rocky, for the question. Cool. I'll hand over to G.
Thank you, Asna. Hi, everyone. So I'm the Senior Health and Wellbeing Coach with a background in nutrition and yoga, also the Personalised Care MDT Faculty Lead, supporting the educators. And I've also been doing quite a lot of work with UCLP. So I've been the operational lead in Havering North, looking at the long-term care frameworks for CVED, in particular proactive prevention and early intervention. So I'm going to talk about how the personalised care roles can really add value to this cohort of patients and others with long-term conditions. Next slide, please. So over the past couple of months, you've heard me talk about the multi-professional personalised care team, social prescribers, health coaches and care coordinators. I'm not going to repeat what I've said, but what I will do is really signpost the personalised care team to the NICE guidelines, which really alludes to supporting change in lifestyle for patients. But what does this actually mean? What does it actually look like? And that's where the personalised care team will conduct a needs assessment on an individual basis with that patient and really explore other factors which are pressing on their well-being and on their minds. And we know that things such as social, environmental and lifestyle factors, and Uzma's just alluded to the cost of living, this is really playing on people's minds, creating this stress, which is the underlying cause of things like blood pressure and CVD later on. So the team itself, social prescribers, as we know, signpost and connect to community resources, housing, finance, and care support. Health coaches really look into having meaningful conversations and are more goal orientated. So they're quite specific in what matters to that patient. And care coordinators will navigate the care, especially invaluable for long-term conditions and for MDT coordination. And of course, we are the bridge between the clinical side, primary care, and the voluntary and the community services and public health. Next slide, please. So this is just showcasing some of the success that I've had personally as a health and wellbeing coach. And this is just patient experience. Patient experience measures. 9 out of 10 patients will say that health coaching has changed their lives, or they've felt an immediate sense of calmness. They gain clarity and confidence, clarity in what's really underlying their well-being, and confidence to speak their truth, confidence to have a more productive conversation with their GP or with the pharmacist because they have clarity now. Self-belief is a big thing in a lot of patients that we actually coach. Sleeping soundly, as we know, sleep is really important for our overall well-being. Achieved a sense of peace. Now, what does peace actually mean? And this is a question that's been on my mind as a health coach for the past 3 years. But one thing it means is being better able to make decisions about their own health. They feel that they are in control and are motivated to make those differences. For me, coaching is about compassion, meeting that patient with a compassionate mind, with a compassionate heart, to really help them uncover what that peace of mind and happiness means and looks like for them. And it's different for different people. Everyone is different. So this is where coaching, social prescribing, and care coordination really meets the patient where they are, in that moment of time when we see them. And more importantly, it's really to create a safe place for that individual to open up and share what's on their mind without feeling judged. Next slide, please. So I'm going to share a story which came to my mind when I was preparing this presentation. And really, this is about a 70-year-old male. He's retired, and he was referred to the personalised care team through Joy. And all we had is that this gentleman is suffering from anxiety. Now, just taking a look at his notes, we, the social prescriber and myself, decided to support this patient. The coaching sessions were about 60 minutes long. There were 6 sessions and tailored to the patient and his response. The first thing I noticed when I met this patient was how I generally tune in. I tune into the patient, make them comfortable, let them know that they are in the driving seat. I am not here to tell them to do anything, or neither am I here to offer them advice. That's not my role. Then I explain what coaching is. Coaching is empowering the patient. So the patient is now in the driving seat. They are in charge. And really what I want to hear is what matters to them today. What is keeping them up at night? What has created that anxiety for them? So we give a little bit of a holistic assessment, and I use a perceived stress score, which is a universal stress score, which just really shows where this patient's at with their lifestyle, with their diet, with their exercise, and other things that might be playing on their mind. So he shared that he's retired, he lives with his extended family, his son, his daughter-in-law. He has really good support, and really his grandchildren are his lifeline. They keep him active. He plays football with them, and they were quite young. So he plays football in the garden, might go to the park for walks and cycling. These are all the things he loves. And this really, you could see it. His face just lightened up when he was sharing this. But a routine auditory, so his ears were playing up. And so he went to the GP and had a check for his auditory and his vision, because he was experiencing dizzy spells. So they checked out his blood pressure, and surprisingly, he was diagnosed with early signs of chronic heart disease. And this kind of like shocked him because he was living a healthy lifestyle, he was eating well, he was active. So this put him in a place of shock and fear. And so when I was sitting with this patient, I could actually see that fear and also sadness in his eyes, and his body language was quite contracted. His shoulders had fallen forward and he was speaking low. There was no kind of happiness or joy in his voice, in his sound. And he said that he'd stopped his activities and he'd become more sedentary, and he'd started comfort eating. So cakes and biscuits and cups of tea is what he started to do. And we kind of like dived a bit deeper into this conversation to why he felt he needed to stop his activity. And he said that his specialist consultant had suggested that he doesn't do any more activity because this may create, have an impact on his current state of health. So he was worried. So because of his worry, he'd stopped walking, he'd stopped playing football, he stopped engaging with his grandchildren, he stopped doing all the things that actually brought him joy. So we looked at what the goals, what his goals were. Now this was meeting him pre-surgery. So he'd actually been referred to me pre-surgery. He was waiting for a surgical date. So I actually saw him through the 4 to 6 months through his kind of surgery period as well. Next slide, please. So coaching with compassion, really he wanted to re-engage with his family without fear. So he really wanted to drop the fear. So the first thing we did was really look at hope, reconnecting him, reassuring him, and encouraging him to do the little things that bring him happiness. We had a really good education session about stress and how stress impacts us, which empowered him to recognize his own triggers, and I signposted him to the British Heart Foundation and other resources which are on here. I also collaborated and coordinated with his GP and with the pharmacy and the rest of the MDT team, just to ensure that the support he was getting to get him back on his feet was holistic. He felt a lot better after the relaxation techniques. And as you know, I do practice and showcase a lot of breathing techniques with my patients, which really bring them back home to their to themselves. I can't stress the value of literally just taking a moment to step out of your mind, the mind talk that creates this kind of bigger stress than what it is, and how powerful that is. We addressed motivation levels, so we started looking at what healthier lifestyle choices were, and his family really stepped in to support him now, to encourage that he's not comfort eating, and we reintroduced activities such as walking, yoga, Tai Chi, and all of these have some scientific evidence that seated yoga, Tai Chi and breathing techniques are very, very useful pre-surgery as well as in your rehabilitation. And we set a realistic timeline when he could really start re-engaging and playing football again. So this looked like 4 to 6 months, and that actually reassured him and put him back in the power seat so he could communicate with his family, with his grandchildren, to say, Papa's not really well at the moment, but this is what he's going to go through, and he'll be back to playing football with you. And he had confidence. He actually had confidence to speak to his family about support. So we did some creative visualization, so he could actually visualize playing football again, because that was the most important thing, re-engaging with his grandchildren. Next slide, please. And these are some of the resources, the information and support that I shared with him, along with the social prescriber, and feeling kind of holistically supported. I'm happy to report that he is back with his grandchildren, playing football again, and this is a year later. So it's really the conversations that count. Happy to take any questions, and thank you for listening.
Thank you very much, G. Thank you. Please, anybody, if you do have any questions, don't hesitate to ask. And whilst you're thinking of questions, if you wish to ask them now, I can send you on the chat, on the Zoom chat, the form that you can click on. It's a link which will take you onto a document where you can put in your answers, multiple choice. It'll take you no more than 10 seconds. The only thing you'll have to write is your name, after which you'll get a certificate. Thank you very much.
I would strongly encourage everybody to do the form. The very reason is that helps us shape future sessions and actually deliver with the needs of my audience. And then Uzma, me, Manpreet, and G, along with Yasmina, who's the glue who holds us together, actually help develop future sessions, which will work according to your training and development needs. So I'd strongly encourage everybody to please fill the form.
Yes, thank you. And also, if you have any speakers in mind that you would like to hear from, please share with us, because we're always looking for new speakers. And if you know anyone that you've heard them and they're really good, just let us know.
Uzma, there's a question in the chat for you, I think, which all of us can answer, because I'm not going to only throw it at Uzma. How do you speak to a client about frailty in a way that is sensitive? I think it's about actually being you. And I think between Uzma and me, I think G would be the best person to answer this question, wouldn't you? In a very personalized manner.
I don't call them frail. I don't talk about it as frailty. I talk to them about like how things are going on. If they've come to see me after a fall, I would like kind of try and help them understand what's going on in their body and how asking questions. I mean, that's what I would do. I don't have a lot of time with each patient, but I don't know, G, if you've got more time, I mean, how would you approach the topic?
Yeah, you've touched on a point there.
Just before G, you started saying that the access to the feedback form is blocked. I'm really sorry, G, to interrupt you, but I agree with Uzma. Me and Uzma avoid using the word frail and chronic, because whenever you say frail and chronic, it's just not a good way.
Yeah, it's the same thing with obesity. It's the same thing with obesity. I don't really talk about them being obese, or if they do ask, and obviously I'll be honest with them and I'll say medically, look, the weight's on the higher side, but we all struggle with weight. So I haven't had any complaints, but I know like my trainees have had complaints about being called obese or fat. I don't use those words, but I will if the patient I feel is ready to hear it. We do talk about being overweight and how it's impacting their knee pain, their hip pain, in the same way, sort of why people are falling, how the muscles is a bit weak, they need a bit of physiotherapy. Yeah. And I will use the word frail if I feel they're ready to hear that. But yes, I'll make sure I'm still managing them as somebody who's got frailty.
Sorry, G, you were saying something.
Yes,
Yeah, I was just going to add, actually, language is so important. So I don't think I ever use the word frail, obese. I don't use the technical language. It's more about just holding the space. It's providing a safe space so they can speak about what's on their mind. And we can see that, especially with heart conditions, they're in a space of vulnerability and also fear. They are so worried about what's going to happen to their families, to them. And so there's this kind of like real cocktail going on in their mind. And for us, it's to reassure them and to help them undo what's playing on their mind, put it down, and then just break it down and work through it. And so yes, language is very important, but it's providing that safe space.
I think it's just Manpreet, sorry.
Sorry. No, I was just going to say that. I mean, in the past when we used to do a lot of frailty reviews, one of the things that I noticed is that a lot of patients have already recognized their frailty. By the time that you're seeing them, they're beginning to realize it already, really. So you don't really even need to use the words. You just talk about the present, the symptoms, their symptoms, how they're getting on with it, and any of their shortcomings that they find. Usually that's a bit of a signal for them that, okay, there's a bit of frailty in there, sort of thing. So I think actually, and that too, older patients, they tend to realize that even before they're frail, they will say, I'm old and I'm frail. They have a bit of a sense of humor about it, I think. So I think just sort of just tailoring it, getting to know your patient and the character of your patient, I think it's not usually as hard as we would think it was.
And I would just like to add, there was something Uzma, you and Yasmina talked about. There are certain things run by the training hub, like the motivational interviewing and things. If you think that that's one of your areas that you need to work on to make it your strength, I would suggest do the motivational interviewing. That really, really helps you overcome that barrier and what to use, and they have various things come out. So I've done it. I've done the motivational interviewing, and I find it so helpful.
Yeah,
I get my
and
trainees to
also,
do it.
yeah, and also your local hospice would have a lot of training resources about how to have that difficult conversation about end of life, especially if you recognize somebody is, because it saves the whole family a lot of heartache later on if somebody suddenly dies and they weren't expecting that. And whilst you all along knew that this person, you know, is in that end of life, you don't know how long is a piece of string, but you know, so, and how can you be honest about your feelings about end of life with the patient? So it gives them a bit of space, and they'll be very grateful to you for helping them understand that what phase of life are they actually entering. But there are ways, and I think the beginning of it is the trust, is the rapport you have with the patient. I wouldn't feel comfortable talking about it to a complete stranger that I've never met before. I know it's rare now because I've been working at the surgery for so long. I know most of my patients, especially the complex ones, because they always get left for me. But even on my first visit, sometimes if the patient's really pushing me, and you know, it's just like for them, they want to know. It's just the penny drops at some point, and they realize that, okay, you know, it's getting, I'm getting ill. So yeah, so it depends on a lot of things. I think it gets easier, and I'm sure, Ivy, you're already doing that, you know. So yeah, thank you.
And you get better as long as the more you do it, the better you become at it. It's just practice. The more
And you've
you
got
do it,
endorsement from Kim.
yes. I mean,
Motivation Kim.
Uzma and I probably, Uzma, me, Manpreet, and G, we've probably been doing it so much that now it's become second nature to us. So
I
it's
think
just
it became better when I did the care homes. I looked after a care home with 120 beds, and every day was the same conversation I was having with their relatives. And people do die a lot, like in care homes. I just like, I've not seen so much death. I did it for about 8 months. Yeah, and I think that's what really made me better because I was doing it so often. But I know we don't always get to do it that often, and I think that's great if you know, because I think seeing death a lot, it does have an impact on you as well. So yeah.
Yeah, you're right, Asma. I did end of life care for about 5 years unknowingly, and it just becomes second nature to have those conversations.
And you know, I realize I'm not alone, you know, in this. The care home staff, the care coordinator, you know, you've got the end of life facilitator. They all help with these difficult conversations.
thank
Thank
you
you so much,
everybody for a
everyone.
very, yeah, thank you
Sorry.
everybody for a very useful session.
Thank you. Thank you, everyone. Thank you for coming. Thank you, Anjali, again, for coming.